I'm going to talk to you all today about women and epilepsy, both pregnancy and beyond. So we're going to cover a lot of things, and I will open it up for questions at the end. But we're going to talk a little bit about hormones and the menstrual cycle and kind of how that can play a role in your epilepsy, sometimes improving it, sometimes making it worse. A little bit about sexuality, contraception, and what options you have, pregnancy and fetal outcomes, breastfeeding, because sometimes there's a lot of questions about that, especially with if you're on different anti-seizure medications. And then we're going to wrap it up talking a little bit about menopause, so how that can affect your seizures later in life, and also bone health really throughout your life. So it focuses a little bit more on the earlier years, but I think it's important to really look at women as a whole in their treatment with epilepsy. So first, we'll talk about the relationship of epilepsy and the menstrual cycle. So many women have an association between the menstrual cycle and their seizures. It's actually thought to sometimes be up to 50%. And we know that seizures can peak at different parts in the menstrual cycle, whether it be near ovulation or near when you're about to have your menstruation. And I'll kind of show you a graph to explain that a little bit. And then we know that your hormone levels play a role in seizures as well. So when you have high estrogen levels, that actually can worsen seizures. So I think of kind of E for estrogen and E for, the word I use is usually elevation or exacerbation, which is kind of a bigger word, but kind of an increase in seizure activity. Whereas high progesterone actually decreases seizures, so it's protective. So I think about P for progesterone and P for protection, and it reduces or can help reduce seizure activity. And we know that high levels of estrogen also can lower some anti-epileptic drug levels, which can also increase risk of seizures. So for example, estrogen can actually interact with lamictal or lamotrigine and actually cause a lower level of lamictal and potentially increase a risk of a breakthrough seizure. So this is just a graph to kind of explain to you guys what happens and why your seizures get worse around different times in your cycle. So estradiol is actually the same, what you can think about as estrogen. And so right here, kind of right in the middle of your cycle at day 14, we talk about ovulation a lot. What's happening during ovulation is that estradiol or that estrogen, that purple line, is actually going up. And as we just said, estrogen can make seizures worse. So a lot of people, a lot of women can have seizures, that are worse right at the middle of their menstrual cycle when their estrogen is high. But I think the most common pattern that women with epilepsy often see is when their seizures get worse right around their menstruation, either right before they start having their menstrual cycle, the bleeding, or right after in a couple days. And what's happening here is when you actually go, towards the end of your cycle at day 28, or the beginning of your cycle, right at day 1, you can see here that the estrogen goes down, but so does the progesterone. So progesterone is very low, and we said that progesterone is protective. So you lose that protection, and that's why you tend to have seizures more during that time. So another way to think about it, as I said, is that estrogen can kind of be proconvulsant or can make seizures worse. And just to step back, when you think about your seizures, sometimes people will think that a seizure happens because your brain is too excited. Or your brain isn't inhibited enough. And so what happens is estrogen actually reduces that inhibition. And so that's why you can have more seizures. And what progesterone does is it increases that inhibition, or kind of like stopping of seizures. And it actually lessens the excitation. And so that's, a little bit of, another level, but of why we think that seizures get worse around your menstrual cycle. And that term of seizures getting worse around your menstrual cycle is actually called catamenial epilepsy or catamenial seizures, if you've ever heard that term. And what that means, again, is that there's increased seizures around your menstrual cycle. And you can have changes in these patterns that are associated with, changes in estrogen and progesterone that can start as early as menarche. So it can start, at 13, 14 years old and basically carry through, the lifetime of your menstrual cycle and sometimes all the way to menopause. And as I mentioned earlier, up to 50% of women can have these epileptic patterns that correspond with their menstrual cycle. So how do we treat it? And so, there's a lot of different thoughts on this. One of the very first things we need to do is figure out if someone has catamenial epilepsy. And the way we do that is we'll actually check to see when you're having your seizures. So we'll ask a patient to keep a calendar. So keep a calendar of when you're going to have your seizures, and then keep a calendar of when you have your menstrual cycle. And what you'll see is, let's say that you come back to your provider and say, you know what, I have seizures once a month, and they're always, day 3 of my menstrual cycle, or they're always a day before I start bleeding. And so that helps us figure out this kind of spatial relationship. Now, if you figure that out, what do you do? And sometimes, we'll try to increase the ASMs, or anti-seizure medication. So we'll try to increase your anti-seizure medication either right before you're about to get your period or during your menstrual cycle. But sometimes that doesn't work. And sometimes what that does is it actually just makes the seizures less predictable. So then they can happen any time of the month, not just around your menses. So some people suggest trying to do a contraceptive pill that has progesterone and estrogen in it. And sometimes we also may suggest kind of intermittent progesterone supplementation. And so there's a lot of different things we try, but no one thing works well, I guess I should say. There's no kind of secret pill or something that we know always helps these seizures. And in fact, these seizures sometimes can be very difficult to treat. So thus, just kind of going back to the treatment of catamenial epilepsy, we'll try many different things, but sometimes what ends up happening is we just have to increase the anti-seizure medication on a whole, not necessarily around certain times of months. So now we're going to talk about sexuality and epilepsy. And this is something that I will be the first to admit that I do not bring up enough with my patients. And you guys probably can kind of speak to that too, of how often your provider asks about this. But it's something that we need to ask about because potentially we can address it. So anywhere from 15 to 50% of patients with epilepsy, both men and women, have decreased sexual desire and performance. And it's thought to be related to the changes in both your androgens, so testosterone and estrogen. And sometimes this can be related to your anti-seizure medications. So for example, an inducing anti-seizure medication is a medication that may break down other things in the body or other medications. And so if that's the case, like we know, for example, carbamazepine or Tegretol can make the sexual desire, can lower it and can cause some issues. So maybe we'll switch your meds. But the thing is we're not going to know to switch your meds unless you bring it up and talk to your provider. And we know that, as I said, some of these medications can cause low hormonal levels, which actually are, contribute to these symptoms that you feel. We know that the medications can also sometimes worsen anxiety and depression, or the fact of having epilepsy in general. The things that you face in your life can worsen anxiety and depression, which can play a role on sexuality. Also, kind of going back, some of these medications can reduce genital blood flow in response to erotic stimulation, and also affect patients specifically with certain types of epilepsy, like temporal lobe epilepsy. And if that's the case, then erectile dysfunction medication can be used to try to increase genital blood flow. Sometimes, kind of related to the anxiety, but patients may have cosmetic concerns. The medications, for example, Depakote can increase weight gain and increase hair growth maybe on your face, but losing hair on your head, both Depakote, Topamax, different drugs can do that. And that can play a role in anxiety and sexual desire. And then lastly, we can't forget that patients who've had seizures, you may be really worried that you might have a seizure during intercourse. And that plays a role as well in development of anxiety. But as I said, the biggest thing is that, we as the providers ideally should be asking about this. Now, not all providers ask about it, as I said, myself included. And if this is something's bothersome and your provider hasn't asked about it, then I encourage you to bring it up to your provider as well. Although obviously we want providers to ask about it, it doesn't always happen. Okay. Next topic is going to be looking at anti-seizure medications and contraception. And this can be very challenging too, because our anti-seizure drugs can actually interact with birth control, and they can make birth control less effective, especially when you're doing oral contraceptive pills. And so part of this is because both the seizure medication and the oral contraceptive pills are broken down in the same pathways in the liver. And so that's why sometimes your oral contraceptive pill gets broken down faster and is thus less effective. And so that's something that needs to be talked about. And because of that, a lot of times we need to talk about alternative contraceptive methods aside from just oral birth control pills. So before I go into that, I want to actually talk to you about how many medications can actually affect your oral contraceptive pills. It's probably more than you realize. And so you can see here carbamazepine, which is Tegretol, oxcarbazepine, which is Trileptal, phenytoin, which is Dilantin, phenobarb, primidone, Topamax or topiramate, and as I said before, birth control actually has an effect on lamotrigine or Lamictal. And again, this has to do with how the medications are broken down in the liver. And you can see here, I have an extra little symbol next to Topamax, and that's because Topamax or topiramate has these effects at a higher dose of 200 or more a day. And as I mentioned before, with lamotrigine, that oral contraceptive pills can basically reduce lamotrigine levels. And so we need to be aware of that and address that as your providers. And then as far as other medications, benzodiazepines like clonazepam that you might use for rescue, gabapentin, levetiracetam, which is Keppra, pregabalin, valproate or valproic acid, zonisamide or Zonegran. All of those are thought to not have interactions with oral contraceptive pills. But the point is that if there are interactions, that we can recommend other things. So for example, let's say that someone had a sexual encounter and they're worried that maybe their birth control wasn't effective. You can use the morning after pill or Plan B. However, Plan B is also affected by some of these anti-seizure drugs, and thus we recommend possibly doubling the first dose. But as far as overall protection against pregnancy is, you can use many other things that aren't oral contraceptive. So for example, you can use Depo-Provera injections. A lot of times those are done once every 3 months. You can get an intrauterine device, like a Paragard, which you can see a picture of over to the right, or the Mirena is another intrauterine contraceptive that both works kind of locally and systemically. The Mirena is one that we recommend that a lot of our patients have tolerated well. And then you also can use barrier devices such as condoms, diaphragms, a cervical cap, an alternative to not just the oral contraceptive, but something else that can help protect. Okay, I know we're kind of moving quickly, but now we're going to go into kind of talking about women with epilepsy in regards to pregnancy. So the first thing I want to kind of step back is that there's 1.5 million women of childbearing age in the United States who have epilepsy. And although there's 1.5 women with epilepsy, seizure medications or anti-seizure medications that are prescribed for many different reasons are actually prescribed in over 4 million patients. You might say, well, wait, that doesn't make sense if you're saying there's only 1.5 million women of childbearing age, but that's because these anti-seizure medications basically can be used to treat mood disorders, pain disorders, and epilepsy. But you can see that they're used significantly in mood disorders, such as depression, bipolar. And so the point is that the data that we have of these drugs in women of childbearing age is there's a lot of women who are exposed to these drugs, and partially even women who don't have epilepsy. But let's focus on women with epilepsy who potentially might be planning pregnancy or thinking about pregnancy in the future. And so I get a lot of questions, and I wanted to capture some of them in this presentation. So I've had women ask me, can I even get pregnant? Believe it or not, I've seen some patients that I have had transferred to my practice who have been told that they shouldn't get pregnant because they have epilepsy or on anti-seizure medications. And that is incorrect. And we'll go through that. Other patients have asked, should I be on anti-seizure medication? If I am, what's the best one to be on? And then I've been asked, will my seizure control change during pregnancy? And so to address some of this, the biggest thing I want you to make sure of is that you're not alone. That women with epilepsy account for 1 in 200 pregnancies in the United States, and over 25,000 children are born to mothers with epilepsy each year. And the majority of patients have, and I'll show you this on another slide, over 90% are healthy pregnancies and healthy normal deliveries. However, and this is why I'm focusing on this, is that 1/3 of patients of women with epilepsy don't even consider having children because of their epilepsy or because of something they may have been told in the past. And that's why I want to provide you with more education today. So there was a study that was actually done over 5 years ago by Dr. Jackie French and Paige Pinnell, who focus on women with epilepsy. And what they showed was that when they compared women with epilepsy to women without epilepsy, that the likelihood of achieving pregnancy was the same, regardless if you had epilepsy or not. So fertility was the same. The time to achieve pregnancy was the same. And when you look at live births versus miscarriages, the pregnancy outcome was the same. So what may change is, possibly an increased risk of birth defects over the general population, which we'll talk about, and also premature delivery or things like that, which I'll also go over with you. But the risk of birth defects in the healthy population, the population without epilepsy, is about 1.6 to 3%. When you look at women with epilepsy, and depending which medications they're on, that risk of a major birth defect can increase up to 6%, even higher on something called valproic acid. But again, as I said, over 90% of women have routine pregnancies and healthy babies. Over 90% of women with epilepsy have routine pregnancies and healthy babies. But there are some rules that we try to follow as your providers. So for example, if we can have you on just one medication, that's safer than 2 medications. So if you have been seizure-free for years and years and you're on more than one medication, we may, talk to you about why you're on more than one medication, if you need more than one medication. Also, let's say that you were put on high doses and you became seizure-free and you've been seizure-free for years. We'll talk about whether you need high doses or, is there a possibility to lower some of the doses of medication. The one thing that's important is that if we're going to have these discussions, they need to be had well before you become pregnant, because it's not a good idea to switch medications during pregnancy. And if we're going to switch medications, we want to make sure you tolerate it well before you were to get pregnant. And there's individual differences for each patient. So we want to find the drug that is best for you. But the evidence has shown that it's not only the type of anti-seizure medication that you're on that may have an effect, but also how much medication you're on. And that's why we really want to address that before you were to get pregnant. So again, I like to use some graphs just to kind of highlight similar things I just talked about. So in general, if a patient's on many medications known as polytherapy, they have an increased risk of developing congenital malformations versus if a patient is on just one drug. You can see, the general population is in red, and then monotherapy is one drug. And so you still have some increased risk of your unborn child developing some congenital malformations, but it's much lower with just one medication. And then when we look across the board of what medications kind of cause the most problems, we've seen that valproic acid really has the highest risk of causing congenital malformations. And we try to protect against that if a patient has to stay on that medication. So there's something called the North American Anti-Epileptic Drug Registry. And this registry was started in 1997. As of 2016, over 10,000 patients have been enrolled. And I don't have an updated number, but obviously more than 10,000 since that was back at 2016. And here it kind of just shows you the trends over time of the different seizure medications. And really, I know this again is a busy slide, but what I want to highlight is lamotrigine or Lamictal and levetiracetam or Keppra have really become the two most frequently used medications in a woman of childbearing age. And I'm going to show you that kind of broken down on the next slide. Now, this is data that actually was just presented at the American Epilepsy Society virtual conference in December and was just updated at the end of October of 2020. And this is looking at the risk of malformations that are specific to different anti-epileptic drugs that patients are on. So you can see here, lamotrigine has been tested in almost 2,500 patients, and the risk of developing a major congenital malformation is about 2%, which I said is equal to that in the general population, because the general population is about 1.5 to 3%. So you can see there is not really an increased risk above the general population in patients on lamotrigine or levetiracetam, which is Keppra. Another drug that I like a lot is oxcarbazepine, which is Trileptal. But again, you want to look at the numbers. So you have almost 2,500 patients tested with lamotrigine, over 1,000 patients tested with levetiracetam, otherwise known as Keppra, over 1,000 patients tested with carbamazepine. And again, with carbamazepine, the level of developing congenital malformation is still considered low, but higher than maybe some of the other drugs. And again, oxcarbazepine is low, but you want to look at the number of patients that have been tested on it. So oxcarbazepine is low, gabapentin is low, and then zonisamide is also, a lower risk. So these are the things that we think about if we're going to potentially change your medications, or even when we start you on a medication, because ideally the medication you're started on, we want to keep you on over time. And then Vimpat or lacosamide, this is new to the registry that was just added. And so there's a range of 0 to 7.4. So more data needs to be done, but at least it's being looked at in the registry, which is important. And 65 patients have been studied with it. And these are all compared to external controls, which is almost 300,000 patients. And these are the medications that really are being looked at in the North American Registry. Even if they're not reported, there's still data being gathered on them. In order to be reported, you have to have at least 150 patients on monotherapy. So that's why you don't see all of these names in the chart I just showed you. So what kind of birth defects are we talking about? So birth defects may involve many different organ systems, and the majority of birth defects that we see might be cleft lip, cleft palate, heart defects, neural tube defects. So that's, when your spinal cord is forming in the first 8 weeks of gestation. You might, if you're on Depakote, you may actually have an abnormality in your neural tube development, and that can lead to spina bifida. Again, that's mainly seen with valproic acid, and that's why we really try to encourage patients, if they don't need to be on that, or women of childbearing age, to not be on valproate if they don't need it. There's other risk factors that are associated with anti-epileptic or anti-seizure medication. And so, for example, I had mentioned cleft lip and cleft palate. That's been seen in patients on lamotrigine at higher doses, Topamax, carbamazepine. We've also seen a lowering IQ in babies born to mothers on certain drugs. So Again, valproate or Depakote is the biggest offender. So mothers who are on Depakote have had babies, be born with lower, I shouldn't say be born, but basically over time, have lower IQ, potentially 8 points lower than mothers who are born to mothers on Depakote. They've also seen some lowered IQ in Dilantin, Tegretol, or Lamictal, but that's much lower. And they've actually seen that, Depakote really lowers the IQ much more than any of these other drugs. And so this NEED study basically is looking at neurodevelopment in women who've had women with epilepsy that have had children. And so the chance of having a lower IQ or IQ lower than 70, again, as I said, you can see it in some other drugs, but you really see it the greatest in children that are born to mothers on valproic acid. So I told you that Lamictal is one of the most common drugs, and the likelihood of this happening is 2% or less. Lower IQ has been linked to younger maternal age, to patients not taking folic acid. So you'll see that if you're in childbearing age, regardless of planning pregnancy, your providers often will recommend that you are on folic acid. And so as soon as I get a patient that transitions from pediatric care to my adult clinic, I put them on folic acid right away. Also, lower socioeconomic status or the dose of medication has also been related to lower IQ. And then again, as I said, with valproic acid, the IQ has been shown to be 9 to 10 points lower for children exposed to Depakote over 800 milligrams a day. And that these patients will likely need or have an increased need for educational intervention. But it is thought that if a woman of childbearing age needs to be on Depakote, that if they can be on a dose less than 500, that's thought to be safer, and you don't see necessarily the spina bifida or neural tube defects. The IQ also is thought to not be reduced as much. So the other thing, now this is an article that just came out in October again of 2020, and basically it was looking at anti-seizure medication in pregnancy and looking at the increased risk of autism spectrum disorder or attention deficit and hyperactivity. And really, again, what they found was that this increased risk was associated with valproic acid. It was not associated with lamotrigine or other medications. But again, this is the reason why we really try to get women of childbearing age. We try to keep them off of valproic acid and or switch it if possible, because there are increased risks of autism spectrum disorder or development of ADHD in children born to mothers on valproic acid. So how do we try to protect? If you have to be on valproic acid, or in general, if you're on any anti-seizure medication, as I said, there can be an increased risk to develop congenital malformations. How do we protect against that? So what we do is we put patients on folic acid, and usually we put patients on additional folic acid. So as you know, a prenatal vitamin may have about 0.4 milligrams of folic acid, but we really want patients to be on additional 1 milligram daily. And so that's what we will recommend. And actually taking folic acid even before conception has been linked to higher IQ in babies. So what are the, abnormalities that we're worried about? What drugs are associated with increased congenital malformations of anti-seizure medications? And so there used to be this old categorization looking at, putting drugs in either category C or category D, and really cautioning against being on certain drugs. And this could be very confusing because there was not a lot of data. And sometimes it was only animal data, it wasn't human data. And it actually could lead to a lot of anxiety in women with epilepsy trying to have babies, because you would see that, you know, in category C, there either would be animal studies or maybe human studies, or human studies weren't available. And so what happened is the FDA actually changed their categories. And so what they did is they then started giving recommendations for pregnancy, using the pregnancy registry, kind of giving you a risk summary, also talking about lactation and risks with lactation. And so basically it was thought that this gives a little bit more information to the patient who is thinking about getting pregnant, and also a little bit more information about the drug, so that you can, you know, have a little bit of an educated discussion and decision with your healthcare provider, and also to know, you know, what the risks are. So some of what we found and what I mentioned before is that it's better to be on one drug at a lower dose than multiple drugs. And so we found that the risk of major congenital malformations was actually reduced on a single drug. And all of that being said, if you are a patient who has generalized tonic-clonic seizures during pregnancy, that can actually cause more harm. So if you have generalized tonic-clonic seizures, you need to be on the amount of medications that can control your seizures. And it's better to be on 2 drugs if you're having seizures than 1 drug that doesn't control your seizures. So although, you know, I'm giving you the ideal recommendations and guidelines, it really is individualized to each patient and how severe the patient's epilepsy is. So what about using anti-epileptic drugs? Can anti-epileptic drugs be discontinued? And if they're going to be discontinued prior to having pregnancy, there needs to be a discussion, and it needs to be done well before the patient gets pregnant. And so basically, we would want you to be seizure-free for at least 2 years. And we'd want you to understand that even if you're seizure-free, if we take you off the medication, there's always a risk that seizures can recur. And that's why we will ask you to kind of wait 6 months. So if we take you off the medication, we want to wait at least 6 months before you attempt pregnancy, because we want to make sure that you remain seizure-free. We don't want you to get pregnant and then be having breakthrough seizures, because as I said, that can be dangerous for the baby, and even more dangerous than the increased risk of congenital malformations, sometimes seen with the anti-seizure medication. And again, why not just stop the drug? And as I said before, there can be negative consequences. So if a patient has a seizure, it can lower fetal heart rate, it can cause premature delivery, it can lower both you and your baby's oxygen levels. You can fall and get hurt and have abdominal trauma, even fetal death, and also, you know, with more seizures and things like that, increased risk of learning disabilities. So what we kind of say is, you know, looking at seizure frequency compared to pre-pregnancy baseline, you know, what are the things to consider, and, you know, what are the things that we even as providers think about in the back of our head. So studies report that basically up to 50, you know, anywhere from 20 to 50%, but even higher, of women have seizure worsening during pregnancy compared to baseline. And there's many factors that are involved in that, but sometimes that can just be because doses of medication have dropped, in whether a patient has just kind of stopped their medications or self-reduced their medications, or because as you get pregnant, your body revs up and your metabolism revs up. And if you're not monitored, your drug levels may fall. And so ideally, you know, if we make sure that your medications, you know, stay at appropriate dose and that your blood level stays in an appropriate dose, we ideally, you know, can try to protect you the best that way. And so the thought is that, you know, depending on how controlled your seizures are prior to delivery, prior to even conception, that's kind of where ideally your seizures will stay during your pregnancy. But obviously we take into account if you have focal seizures versus generalized seizures. Generalized tonic-clonic seizures can cause more harm to mothers and unborn fetuses. Obviously, we want to try for, you know, one drug if we can, and, you know, put you on the drug that is associated with the least amount of side effects or congenital malformations. We want to do therapeutic drug monitoring to make sure that your levels stay the same throughout your pregnancy. We want to make sure that you don't self-discontinue your medication or lower your medication doses. And then we also need to make sure that you're having enough, good sleep, stress management, things like that, that can also lower seizure control. And so if we're going to switch a medication, again, we want to do that well before you conceive and make sure that you're tolerating this medication well and not having breakthrough seizures. And obviously different medications can work differently for different patients, and that's why we really have to make sure before you were to get pregnant of what works best for you. And so during pregnancy, you will check your blood levels routinely to make sure that the drug levels haven't fallen. We'll continue on folic acid and prenatal vitamins. We'll recommend finding a high-risk OB that will do an anatomic ultrasound and follow you closely for any neural tube developments or any congenital malformations. And we also encourage you to enroll in that anti-epileptic drug pregnancy registry so that we continue to get more information for our future patients who are thinking about pregnancy and or what drugs to be on. What other things are important? So high levels of hormones can cause drug levels to fall, as we talked about already. Changes in levels due to increased metabolism can be something that's encountered during pregnancy. As I mentioned before, estrogen can lower a lamictal level, and thus we really want to follow that during pregnancy. And there's other drugs as well that we need to follow during pregnancy. And the reason that we put you on additional folic acid, and might even put you on even more depending on the drug you're on, is because some of our drugs actually will lower folic acid in the body. And we know that folic acid helps prevent against congenital malformations and neural tube defects. And also that higher doses may be associated with improved cognitive outcomes. And so these, as I said, will monitor different drug levels, lamotrigine, carbamazepine, phenytoin, levetiracetam, which is Keppra, oxcarbazepine. So we'll monitor these throughout your pregnancy and make sure that the drug levels don't fall. And also, if we do have to increase your doses during pregnancy prior to delivery, we'll talk about a plan for how to reduce those medications after you deliver, and also talk about a delivery plan. And there's many different recommendations put forth by the American Academy of Neurology and American Epilepsy Society. They've also shown that there's no risk of increased C-sections, there's no risk of premature contractions or premature labor, and that women taking anti-seizure meds, they may have a risk in mild preeclampsia or gestational hypertension, but again, they'll be monitored. Or possible delivery before 34 weeks. But again, this will be something that is monitored. And the biggest thing that's important is that a woman with epilepsy should be encouraged to have a hospital delivery, because there could be increased risk of complications. And we just want to make sure that you're protected. Postpartum wise, as I said, if your medications were increased, then we'll come up with a plan to reduce your medications after you deliver. That definitely is needed with lamotrigine, because lamotrigine often is increased during pregnancy. We also will talk to you about avoiding sleep deprivation and also discuss the benefits of breastfeeding. So breastfeeding advantages, and again, I want to step back and say that breastfeeding is an individual decision. And so if you want to breastfeed versus not breastfeed, that is something that is a personal, individualized decision. However, what we want to say is that if you want to breastfeed, we don't want you to decide not to just because you're on anti-seizure medications, because it has been shown that there is improvement in cognition in babies of moms who've breastfed, and it's been shown that it is safe with a lot of the anti-seizure medication. And so breastfeeding is thought to show reduced in infant mortality, reduced in infant infection, reduced in infant autoimmune diseases, possible improvement in outcomes in infants, although with that data, there could be some selection bias, but it is cheaper than formula, which is something to think about. And then infants with anti-epileptic drugs. So if you have an infant who is being breastfed, keep in mind that dose of drug that they're seeing when in the breast milk is much lower than what they saw when they were actually during gestation and in the mother. But obviously you'll want to monitor for any side effects. You want to monitor to make sure that the patient hasn't become, more lethargic or tired. And if that's the case, then a pediatrician can draw a serum level. So you just want to make sure that, the baby doesn't have any failure to thrive, poor feeding, increased sedation. Another thing is kind of safety during motherhood in patients with epilepsy. So you take your medications despite changes in routine. Make sure you don't miss any of your medications. You rest when the child rests. You replace some of the nighttime feeds with a bottle so that you can get adequate sleep. It's recommended to try to get at least 1 4-hour increment of sleep. I know that can be really hard. And that's why we say maybe supplement a feed with a bottle or even with formula. Don't sleep with the baby in bed. When you feed the baby, make sure that the baby's supported, that you're sitting somewhere safe. A lot of times we'll say maybe feed the baby on the ground. We'll also say maybe change the baby on the ground. Do not bathe the baby alone. If you were to have a seizure with alteration of awareness and the baby were being bathed, they could slip under the water and drown. The other thing is that, we say to kind of, this is the next thing, is have a safe place where you can put the baby if you feel a seizure coming on. So have a plan to protect the baby. Start with kind of a home safety assessment, in each room, know where you might want to put them. If you don't fall with your seizures, you might want to use kind of like a cloth to keep the baby, close to you when you're walking or standing. But if you fall with seizures, obviously that is not ideal. Sometimes if you fall with seizures, it's been suggested to potentially carry the baby in almost a car seat or something like that. But again, you can talk to your providers about this. Lastly, I do want to hit on postpartum depression because women with epilepsy can have an increased risk of development of postpartum depression. Part of that is because women with epilepsy have premorbid depression, and so that sets them up for an increased risk of developing postpartum depression. And that can develop anytime from the second trimester to 6 months postpartum. And as I said, there's an increased risk in women with epilepsy, and especially if they've had pre-existing mood disorders or an unplanned pregnancy. And treatment is available, and that's why we really encourage you to let us know as providers, and we should be asking about it as well. So I just have 2 more minutes, and then we'll have about 10 minutes of questions at the end. So epilepsy at menopause. So as I said, hormones play a role in seizures. And so, perimenopausal, where you have, fluctuations of ovarian steroid levels in your body may worsen or diminish seizures, really depends on the patient. Menopause, actually, seizures may improve, especially if you had that catamenial pattern or seizures that were worsened with epilepsy. However, again, some patients may not change at all, or sometimes seizures can still worsen. Hormonal replacement with unopposed estrogen may worsen seizures. So that's something you want to talk about with both your OB and your provider. But again, overall, majority of patients have no changes in seizures with menopause. But again, you can have increases and decreases. So that's why we need to kind of talk about it and be aware of it. And then lastly, just talking about epilepsy and bone health. So women with epilepsy have double the risk of bone fractures relative to women without epilepsy. And part of that is because you could have seizure-related trauma. You could have, unsteady walking, but or poor balance because of the medications you're on. But the medications that you're on can also sometimes reduce your vitamin D. Basically, it speeds up the breakdown of vitamin D in your liver, so you have lower vitamin D levels. And if you don't have enough vitamin D, vitamin D is used to absorb calcium in the bones, and you can develop osteoporosis. And so thus you can be at increased risk of bone fractures. And so there's certain medications that do this, that kind of lead to that reduction in vitamin D. And those include carbamazepine, phenytoin, phenobarb, primidone, topamax, oxcarbazepine, valproic acid. So it's important for us as providers to test your vitamin D levels and make sure that you're not deficient in vitamin D. And if you are, to put you on vitamin D supplementation. And I probably test this in most of my patients. And so we'll check vitamin D serum levels, and likely, as I said, if they're low, we'll put you on, supplementation. Possibly, the average seems to be about 2,000 international units per day, but we can base that on level and then recheck your level to make sure that you are responding to the supplementation. In patients who are over 50 years of age on a known drug that lowers vitamin D, you should also have something called a DEXA scan, which is kind of an x-ray of your bone density to make sure that your bones are not weak. And again, if they are, a lot of times then we'll refer you even to an endocrinologist or a rheumatologist to actually focus on treatment of bone density to try to build back up if you can, or at least prevent further loss of bone density. This I have in here is just an example to show you, depending on your vitamin D level. So the vitamin D level is what's over to the left, where you see like less than 10, less than 30, up to less than 30. We ideally want your vitamin D greater than 30. And if it's less than 30, depending on how far below 30 it is, we'll make recommendations for vitamin D supplementation and then recheck a level. So in conclusion, going over the whole presentation, it's important for your provider and you to have conversations about your menstrual history, contraceptive planning, also, pregnancy planning, postpartum safety, and also incidents of postpartum depression, bone health for pregnancy. Most women with epilepsy who become pregnant will have healthy pregnancies and healthy babies, over 90%, but you want to make sure that you have good care both before and during pregnancy, and that's key. And then lastly, as far as, throughout your lifetime, you want to make sure, that you're on folic acid, especially if you're in childbearing age, to protect against any kind of congenital malformation, whether in planned or unplanned pregnancies. And also vitamin D for all ages to protect and improve bone health. Here are some resources of things that I talked about, and also that the Epilepsy Foundation can also help provide. And that is the end of my presentation. So I am going to stop sharing my screen, and so we can open it up for questions.
Thank you so much, Dr. Becker, for that presentation. That was really, really informative. Really appreciate it. If anybody has questions, please feel free to share via the chat function. And kind of while we're waiting for anything to roll in, I'll just sort of finish up with some closing remarks. So I did just want to thank everybody for joining today's seminar. I hope everybody found the information really helpful and informative. We'll be sending out a brief email survey after the conclusion, so just keep an eye out for that. And then additionally, I just wanted to make note of some of Epilepsy Association's upcoming events. So this is the first seminar of the year, so be sure to take a look at the other Epilepsy Association seminars that we will have available to you throughout the year. And then we also have several other special events coming up, including our Purple Your Year initiatives, which help raise epilepsy awareness, not only on Purple Day, which is this Friday, I believe, but throughout the year. So please visit our website for a full list of activities and other ways to get more involved with the agency. So I do see we have a couple questions here. Can you see those, Dr. Becker?
Yes, I can. So, so just kind of for the audience too, and to make sure that I can address the question, when you say, so the first question I should say says, any studies of women with epilepsy who use natural family planning? So when you say natural family planning, I'm not sure exactly what you mean. If you mean, I guess I should just ask you if you can clarify that. If that's, not on birth control or just kind of regular, trying to get pregnant. As I said, there's not really any difference in fertility and the time to get pregnant when comparing patients with and without epilepsy. So I don't know if you can write in and kind of clarify a little bit further what you mean by natural planning so that I can address that. the next question, are there specific tests to measure hormone levels? So yes, there can be. So that usually goes through with your OB. So the thing is that it's a little bit hard, as I said, to target, when you have high estrogen levels or low progesterone levels. And what we found is when we tried to target that, especially in patients with catamenial epilepsy, a lot of times what happens is that you had very predictable seizures, and that you had them around your menstrual cycle and you knew when they were going to occur. And then when we tried to target, when you had high estrogen or when you had low progesterone, to try to prevent seizures, what happened is the seizures then became unpredictable and just moved in the course of a month. And so that's why I said we don't have like a perfect treatment for catamenial epilepsy. And a lot of times we'll try many different things. What I end up having to have done is I try like rescue medications around the menstrual cycle, but in the end, a lot of times I end up having to just increase the medication or increase the anti-seizure medication just kind of around the menstrual cycle, but it doesn't work for everybody. The other thing that I've tried to do that has sometimes worked is put you on a birth control that is like where you don't get your menstrual cycle for 3 months. And so like a seasonic or something like that kind of tries to help lessen the hormone fluctuation. And sometimes with the IUD, that, as you know, like if you're on an IUD, sometimes you don't bleed as much, you don't get your menstrual cycles. So something, that lessens your menstrual cycles to lessen the fluctuation of hormones. But again, there's no perfect solution. But I feel like when I've used the birth control, or, whether it be an IUD or an extended birth control, that seems to help the most. Okay. So scientific method. So Eleanor actually clarified. So for as far as natural family planning. So scientific method of keeping track of temperature and other physical signs of ovulation for planning pregnancy and or having more success with getting pregnant. So again, with the study done by Jackie French and Paige Pinnell, they saw that really there was no difference in comparing patients with epilepsy to patients without epilepsy as far as being able to conceive and time to conceive. So the thought is that you would use the same scientific method that someone without epilepsy would use. So when you're trying to plan pregnancy, using that temperature and ovulation kits is definitely recommended and no different than someone who's not pregnant. I don't think there's any specific studies I could say about that, but what I can say is that, women without epilepsy have issues conceiving. In fact, many women do, as well as women with epilepsy. And I have actually had many patients who've gone through infertility treatment successfully. The one thing that I do is that when you're starting if you go through infertility and you have to get some injections and estrogen injections, I basically, during that time, just check your seizure medication levels to make sure that they don't change. And so, but like I said, I've had many people go through fertility and have healthy babies and no breakthrough seizures or no issues with seizures during their fertility treatments. So that's something to kind of note as well. And so I would make the same recommendations, if you're having a hard time conceiving, to look into, to meet with a fertility specialist, to look at intrauterine IUIs or intrauterine, I guess, methods, as well as IVF methods. But again, it hasn't shown to be treated really any differently than someone who does not have epilepsy. On breastfeeding, can babies take in the medication as well? So yeah, so what happens with breastfeeding is that some of the medications may pass through the breast milk, but some of them pass through it in a very small amount. So for example, levetiracetam or Keppra passes through the breast milk in a very, very small amount. The thought is that, the amount that the babies are getting is much less than they got during gestation. So while they were, in utero, they were seeing much higher levels. So they see much lower levels in breastfeeding. But there have been studies that have shown that breastfeeding is still encouraged by both the American Academy of Neurology and the American Epilepsy Society. And actually, this last American Epilepsy Society conference, there's always a pregnancy in women special interest group for providers to log on to. And I actually listened to it twice because it was in the virtual setting, so you could do that. And they did a study actually looking at babies born to mothers with epilepsy who both did breastfeed and did not breastfeed. And they saw that the babies that were born to mothers with epilepsy who breastfed actually had higher IQ. And so they again support the recommendation to breastfeed. Now, that being said, I really think this is important, is it's an individual decision. And so really what, the organizations want you to be able to do is make the decision that you want to, regardless if you're on an anti-seizure medication. But they have shown that the breastfeeding can help with IQ and actually have higher IQ. But that being said, some of those studies have other confounding variables. And so that's why I really want you to make the decision that's best for you. Let's see. Okay. So someone else wrote in about post-traumatic stress disorder. So if you guys can I'm not sure if you can see the questions too, but PTSD is post-traumatic stress disorder. And basically had an early delivery. And then the baby was actually born with a heart condition, but without seizures. Okay. And so the question kind of is, what's the recommendation of having another child, if someone's having a problem with their medications. And so here's the thing is that, as I said, the general population, there's, a 1.5 or 1 to 2% chance of congenital malformations. And so you don't know if that's necessarily related to the anti-seizure medications you were on. So what I suggest is that you see an epilepsy specialist. And I will tell you that I started at MetroHealth a pregnancy and epilepsy clinic. And so typically it's a clinic once a month that's saved for anyone who is pregnant with epilepsy. And then I basically see you, at every trimester and also postpartum to assess for depression. But I also can see patients who are doing contraceptive planning and to basically have a discussion. And then the other thing is that to have a preconception appointment with someone in maternal fetal medicine. And so they can talk to you about your risks, and also to be followed by someone in maternal fetal medicine throughout your pregnancy. And as I said, there might be many different reasons why your daughter had a heart condition. And the other thing is that there are newer medications out there, or I'm not sure, what medications you've been tried on, but we do have medications that are shown to be associated with lower risk, and or being followed with high risk OB to kind of really mitigate the risk or try to follow the risk and give you the most information possible. So kind of just I know I kind of said that in a long answer, but my recommendation would be that, without knowing much more information, I can't say, whether it would be smart to have another child or not, but I do think that, just in the little bit that you told me, that this doesn't necessarily say that you shouldn't try again, and that to see an epilepsy specialist, make sure you're on the best meds, make sure we can try to get your drugs. Oops, sorry, I think I just hit something with my finger. Try to make sure that you're on the best medication regimen for you, and also follow with maternal fetal medicine. I can tell you that I have had many patients that have been on multiple seizure medications, deliver healthy babies. I have a patient who was on valproic acid, and that was the only drug that controlled her. So she had to stay on it, but that we were able to at least lower the dose. I've had patients on medications that have been associated with cardiac defects. And again, they were kind of managed through the pregnancy and didn't have any issues. And that 90% of patients don't have congenital malformations. And some of that's also with making sure you're on folic acid and prenatal. So there's a lot of things that we can do to try to prevent that. And so that would be something, you know, per an individual that we would kind of address and focus on. But good questions.
So thank you so much. I think that kind of concludes our time for today. Appreciate the questions. We appreciate your time, Dr. Becker. So thank you. And I just wanted to thank everybody again for attending this year's Purple Day seminar. Have a great afternoon and stay safe. And we hope to see you at future seminars.
Thank you all for the opportunity to speak with you today. Bye.
Take care, everyone.
Thank you.
Bye, everybody. Thank you.